A 52 years old male patient, ex-smoker known to be diabetic, hypertensive, complaining of diarrhea for about 4 months and lower limb edema for 2 months before admission. The patient complained of diffuse colic abdominal pain, not referred to any site and not related to food, associated with constipation with no other gastrointestinal manifestations, for which the patient sought medical advice and diagnosed as H. pylori positive and received medical treatment for 1 month. Days later, patient developed diarrhea, 8 to 10 motions per day, watery, associated with tenesmus and diffuse abdominal pain with no other gastrointestinal manifestations. Diarrhea was persistent, for which the patient sought medical advice but with no diagnosis. 2 months ago, the patient started to complain of bilateral pitting, non-painful, non-tender lower limb edema, which was progressive. There was no other gastrointestinal manifestation, cardiac, respiratory, neurological, or autoimmune manifestation, with no history of drug intake or irrelevant past history. On admission, the patient was fully conscious, well-oriented to time, place, person, lying flat on bed. Vitals was normal. Random blood sugar was 1.3, oxygen saturation normal. Clinical examination revealed pallor, bilateral pitting, non-tender lower limb edema up to the anterior superior iliac spine, scrotal edema with no other abnormalities. Labs, only the abnormality was in anemia, microcytic hypochromic anemia, and calprotectin 2200. Albumin was 1.4. Hemoglobin was not improving during stay in hospital. Hemoglobin was 8.7, TLC 20.3. Liver functions were normal. Electrolytes were normal except the calcium 6.6. Albumin creatinine ratio was normal. Urine analysis, pus cells 30 to 35. Stool analysis, culture negative, ANA negative, C3, C4 not consumed, CRB normal, TSH normal. Imaging revealed bright average sized liver, enlarged prostate, minimal ascites, and large segmental bowel mass on the right side for colonoscopy. Summary: 52 years old diabetic hypertensive male patient complaining of progressive diarrhea for 4 months and progressive lower limb edema for 2 months. Microcytic hypochromic anemia, hypoalbuminemia, pallor, bilateral lower limb edema, scrotal edema, ultrasound revealing right bowel mass. Colonoscopy was done, revealing a large fungating mass in the cecum extending up to the mid-ascending colon. Multiple biopsies were taken for histopathological examination. Histopathology examination revealed adenocarcinoma and was referred to the surgery. Right hemocolectomy was done, revealing highly invasive differentiated adenocarcinoma invading the subserosal fat and infiltrating the appendix through the muscular wall with no involvement of the serosa. Ileal and colonic margins were free. Take-home message: any patient presenting with change in bowel habit should be investigated. Colonoscopy is mandatory in the presence of red flags: long-standing constipation, diarrhea, weight loss, anemia of unknown cause, gastrointestinal bleeding, low-grade fever, family history for gastrointestinal tumors. Tumor markers are not useful in early diagnosis of cancer colon. All patients above the age of 50 years should undergo screening for gastrointestinal malignancy with upper and lower endoscopies.